And I'm excited to announce our speaker for today, Dr. Quam. And she currently practices at McFarland Clinic in Carroll, Iowa. She completed her Bachelor of Science degree at Iowa State University, her family medicine residency at Broadlawns Medical Center, and she received her Doctor of Osteopathic Medicine at Des Moines University. Her medical interests include women's health and obstetrical care, which is fantastic because that is exactly what we want to talk about today, especially as we're talking about rural healthcare throughout Iowa, which is majority rural. So I'm going to go ahead and hand things over to Dr. Quam to take it from there.
Well, thank you, Christina. I'm really excited to be talking about something that I'm just so passionate about. So as Christina said, I am Dr. Carly Quam. I've been in Carroll, Iowa this is my 10th year. I ended up in Carroll because I really wanted to practice full scope family practice and specifically obstetrical care. And so this idea of, providing quality rural obstetrics is just near and dear to my heart and has given me basically drive to continue doing what I'm doing. So I'm excited to talk about it, both routine care and emergencies. If anyone has any questions as the presentation goes on, don't hesitate to speak up or put something in the chat, and Christina can definitely let us know. I don't have any disclosures. As most of you guys know that are on this, access to OB care is a nationwide problem. So throughout the United States, in that first picture there, you're going to see that the rural states, specifically Iowa, we have lost 20 to 30% of our OB access in the state of Iowa, but across the nation in all these rural areas. And so there's just more and more rural care that is actually taking on more of a scope in an area. And there's more maternity care deserts where there's just not OB units and OB providers available. So what we do in rural obstetrical care is just more and more important to continue doing what we're doing and providing that care to patients so that they don't have to travel miles and miles to safely deliver their babies and have quality care during their pregnancies. In Iowa, we have 54 birthing hospitals. 33 of our counties are considered maternity deserts, and there's been 43 OB unit closures since 2000. And that is just it's something that we want to halt. We don't want to see any more OB hospitals close, and we want to continue to strengthen the hospitals that are there. And the way to do that is to provide high quality care because OB is such a high risk, high reward part of healthcare. If we don't provide high quality care and we get into a lawsuit or we have bad outcomes, then units close and then we have more maternity deserts. Iowa in itself is also just a place where there's just not enough physicians. If you look at the chart on the right, you can see that this is updated just of 2022, but the number of physicians and then obstetric gynecologists per person continues to go down. And so it's a real problem, but we can show that it can be done well. So this is us in Carroll. I put the map up. This is a map of the OB units around us. So Carroll's kind of considered west central Iowa. And west of us is where there's definitely some major OB deserts where units have closed. And so you can see Carroll has a big wide swath that we take from. So our local population here in Carroll is about 10,000. And we are St. Anthony Regional is where we deliver here. And we serve 12 to 14 counties per year. And that number continues to go up. Patients travel from a long ways to come see us just due to how many units have closed. And with that, our births per year have gone up. You can see from 2020, we averaged about 320, and now we're on track to hit almost 400 births at our birthing unit this year. So we prove that you can provide high quality, high quantity OB care even in a town of 10,000 people. And I just kind of want to talk about how we do that and then how we approach emergencies when they do come and how we send our patients to those higher level of care when we need it. So I think the main way that we provide high quality OB care is because we have a great team. And I'm sure many of you come from places across the state that do the same thing. And it's such a team approach. You know, I'm one doctor, but I couldn't do what I do without the team. So I've got this amazing group of labor and delivery nurses that are passionate about what they want to do. They care about their patients. They care about continuing their medical education. They care about coming and staying. You know, it's one part of our hospital where we don't have travel nurses. We are able to maintain and retain these wonderful nurses, and that makes it so that we can be ready to deal with any emergencies as they come. We have a wonderful labor and delivery nurse educator, which is kind of a new role that we've brought on within the last couple of years. And her job is to help us all stay educated, help us all make sure that we're up to date on all the things that we need to as new technology comes out, and helps provide with education and SIMS for our labor and delivery nurses as long as ourselves. We have two lactation consultants and kind of nurse navigators that also help kind of bridge that gap between our patients and providers. Currently, we have 9 delivering physicians. That number kind of waxes and wanes between 9 to 11. But with 9 physicians, there's enough of us that we're able to take care of this quantity of patients safely. 3 of our providers do C-sections, and then we also have general surgeons that provide backup coverage as needed. And then we have a wonderful group of CRNAs that provide our our anesthesia. One of the things that we feel really passionate about when it comes to rural care is making sure that our patients are well educated. And I think St. Anthony's has done a really wonderful job with this, with our lactation consultants and nurse navigators and the pre-birth education that we provide to our patients. This helps us as providers make sure that our patients know what to look for when it comes to emergencies that may arise. They're educated on preterm birth or preterm labor. They're educated on signs and symptoms of preeclampsia. These are all things that we teach them in the office, but sometimes those 10 or 15-minute office visits are not enough to truly drive it home. And so the hospital services, when it comes to our birthplace group, do a really great job of educating our patients and helping them help themselves to make sure that we know if there's a problem that's arising. And I think when you're in rural communities, I think recognition of risk factors and recognition of problems that may arise and planning ahead is so important, because to get patients where they need to go, it sometimes takes time. So if you can kind of get your crystal ball out and help figure out what problems may arise, you're going to serve those patients better. So the patient education is really important, both from a prenatal standpoint and postpartum. I know that with the Echo series, we've talked a lot about mental health when it comes to our patients, and I think this is something that our postpartum education and support groups have really helped with too, recognizing those patients that are experiencing any postpartum depression, anxiety, problems with breastfeeding. This group is able to recognize it and get it back to us before maybe we would see them in clinic. So I really think that our hospital does a really great job of education, and I think that's really key when it comes to rural healthcare. I like to talk about how we as a clinic, how we are successful in maintaining such a strong OB care and having providers that still want to deliver babies, especially as family practice obstetrical providers. Part of the reason I came to Carroll was because there were 7 or 8 delivering physicians that were family practice trained, and you could tell that they were well trained and did a great job with their patients. And so we've maintained that. We have 7 providers that deliver, and three of them provide C-section coverage. 2 of our providers are fellowship trained, and then one of our providers did a rural OB residency where she learned to do C-sections during residency. So between the 7 providers and the 3 C-section providers, we're able to provide that 24/7 coverage for our patients without getting burnt out. Something that we initiated within the last year and a half, kind of post-COVID, I think, is when we started this, is that as a group of providers, we get together once a month on a noon hour, and we run through all of our high-risk OB cases. So we take turns and we just go through any cases that we have that would be considered more high risk. This serves kind of two purposes. Number one, we do some coverage for each other when it comes to call. Most of us deliver our own babies, but if we are out of town or sick or have something going on, then our partners are going to cover for our patients. So it's nice for them to know what high risk patients might come down the pipeline. But I think the second and even more important part is it allows us to have a good discussion about, is management appropriate? Would someone else do something different? It allows us to kind of bounce ideas off of each other, and makes us all feel like we are, maintaining that level of knowledge that we need from, the newest provider to the most senior provider. And we've seen a lot of really good things come out of that monthly high risk OB rounds that we do here. And then I can't speak enough about how important it is to get your higher risk OB specialist involved in cases that are potentially more high risk. So we are lucky where we're at here in Carroll. We have access to both the maternal fetal medicine specialists in Omaha as well as Des Moines. And we sometimes use the University of Iowa too for certain cases. So we are very quick to go ahead and get our maternal fetal medicine providers at least involved in kind of the care of these patients. And then our maternal fetal medicine providers do a great job of allowing us to still try to do as much care locally to save our patients from having to be on the road all the time. So if a patient is high risk and needs biophysical profiles twice a week or non-stress tests, we work it out with our maternal fetal medicine docs to make sure that we can try to do some of that testing here and some of our visits here, even if they're going to deliver elsewhere. We also have an OB-GYN provider that's here in clinic twice a month if we need other services there. And then I think the other part of rural medicine is that you're kind of only as good as your next recruit. So I think for people practicing in more rural areas, you have to constantly be thinking about where's my next partner that's going to come in and carry on this tradition of rural obstetrical care, especially for obstetrician and gynecologists. There's just not enough of them in the state. And family practice, less and less docs are coming out of family practice wanting to do obstetrics. And so we really take pride in wanting to bring students in, bring residents in, and kind of show them what it can be as a provider in a rural area, providing that high quality obstetrical care for our patients. And so we've had good success for that, but it's an ongoing thing, and getting those students and residents in really helps. So I wanted to just kind of run through some of the high risk case management. I think the Echo series has done a really good job of kind of going over a lot of the high risk situations when it comes to hemorrhage, hypertension, diabetes. And so I'm not going to go into the weeds on how to manage each of those cases, but I kind of like to talk about what do we do here that we feel comfortable managing and what do we refer on. So we have kind of only a couple really black and white things when it comes to referral to your tertiary care centers. With a discussion through our anesthesiologist as well as kind of equipment, BMIs over 50 are going to be an automatic send to the tertiary centers. So when we have those patients that are coming in with pre-pregnancy BMIs over 50 or BMIs pretty close to that pre-pregnancy, we're going to go ahead and get maternal fetal medicine involved. And again, these are cases where we will see them locally and do care back and forth between maternal fetal medicine or an obstetrician gynecologist in one of the tertiary centers, so that the patient doesn't necessarily have to go to all their visits in one of the cities, but ultimately the delivery would hopefully happen there. We also try to avoid deliveries before 36 weeks simply because we do not have a NICU here. So if we have a patient that we think is going to deliver before 36 weeks, those are ones that we're getting referred to maternal fetal medicine for some co-management. If we feel like there's any major congenital anomalies that would affect the management of the baby immediately after birth, major congenital heart diseases, etc., we're going to get those involved with maternal fetal medicine and ready for delivery at the centers where there is that pediatric care immediately after birth. I think in rural Iowa, one of the biggest holdups of not being able to provide the OB care is actually not that we can't provide the obstetrical care. It's that when we can't manage, we can't give the high quality care to that newborn without that NICU next door. Otherwise, we could probably take care of many, many more of these women, but we want that NICU across the hall if we know that there's something that could benefit baby when it comes to that standpoint. Of course, there's many other things that we would get maternal fetal medicine involved with, but these are going to be the ones that we really are going to try to hopefully deliver at one of those bigger centers. We do offer TOLACs, trial of labor after cesarean here, which I think is a really great thing. When I was in training, the hospital I trained at did not offer TOLACs because the anesthesiologists were not willing to be on call. But we are very thankful that here they're willing to be available, as is our surgical team. And so that's where that team approach really comes in, having anesthesia available, having that surgery crew available in the event that there's any concern of a uterine rupture or an issue with a trial of labor after cesarean. But we've definitely decreased our C-section rates because we offer that service. And then, of course, if you're living in rural Iowa, you can say we're going to send these high-risk patients on, but ultimately you have to be prepared for the worst. So if something walks in your door, active labor, you're going to have to manage them. And so we prepare and we have our plan in place for what we're going to do when emergency walks in. And that could be preterm labors. That could be all of your labor emergencies, postpartum hemorrhages, dystocias, hypertensive disorders. Just being prepared for the worst is really important. And then as we continue to see these maternity care deserts where there's less and less OB availability for obstetrical care, we are going to see more and more patients who just don't seek care because it's either too far for them to go to see a provider. And so we have to be prepared for those patients that have not had any OB care. And those are sometimes some of the scariest and ones that give us the most grief is the little prenatal care. In order to be prepared for all of these emergencies, we, really focus on ongoing education for our providers, our labor and delivery nurses, our CRNAs, even our ER and ED staff. So all of our family practice obstetric providers are also certified. Of course, we all have our NRP and then our stable certifications. This picture here is a recent picture from a sim from the University of Iowa. Some of our providers, as well as our labor and delivery staff, doing a sim on when we were working on that sim there. So I think those things are really important to just make sure that you can work as a team and be prepared for when something bad does happen. Resources that we use if we do get into an emergency where we feel like we are kind of needing to call for help. We use our maternal fetal medicine consults as I talked about through Des Moines, Omaha, or the University of Iowa. And we find that all of our maternal fetal medicine specialists are really great to work with. Many of them give us their cell phone numbers that we can call directly when we have a mutual patient or a case that we want to discuss. So reach out to those providers with the wealth of knowledge and the resources to provide care for those higher risk patients. Mercy recently started with a air med maternal transport team. So they put a maternal nurse and a NICU nurse on the helicopter and will be willing to come get a mom via helicopter if necessary. Of course, in the winter or when we're bad weather, that may not always happen, and that's where we have to be prepared for the worst. But there's are these resources that are there. We also use our NICU transport teams. So if we have a preterm labor and we don't feel like it's safe to send mom because she is too far dilated or hemorrhaging or a reason that she'd be unstable for transport, we're getting on the phone with our NICU teams and getting that transport team to us. So many times I've had a preterm labor and had the helicopter en route as we are getting ready to deliver, so that basically as baby arrives, the NICU team is there to help us with stabilization and subsequent transport. So I think, although we do have all these maternity care deserts, and although we are, a rural state, we do have some really great resources out there in our maternal fetal medicine specialists and in our neonatologists that can help us really get through, almost any crisis, especially if you're kind of working together as a team. So before I go on to some cases, are there any questions, comments, anything I didn't cover that someone has questions about? If not, I'm going to go on to a couple cases